This conference will now be recorded.
Welcome to this week's Journal Club. Once again, the only club still going on despite COVID, with Andrew, Daphne and myself. So if you're new to the Journal Club, we'll just have a quick outline of what to expect for today. So we will give a bit of background about evidence-based medicine and why Journal Club's important. We'll then introduce a clinical scenario for this week and a focus question, the search and selection that's been undertaken to select the best paper for us to look at today. We'll then split into groups to either look at the validity and the results, and then we'll come back together and then discuss what we thought and about how applicable the results can be, and then we'll discuss what's going to be happening next week. So just a little bit on evidence-based medicine. The main principles are kind of looking at the four main concepts, which is looking at the evidence, the environment, the expertise, but also most importantly the patient, and they all need to be thought of in conjunction together. So you can't necessarily extrapolate the evidence without taking everything else into context. The process for today is looking at the clinical scenario, which normally arises something you're unfamiliar with and thinking, is there any structured approach to look into this further? And that's where you create a focus question, do a search based on your question and try and pick out the best piece of evidence, and then appraising that evidence to look to see, are the results valid, what are the results, and if they are valid, do they even apply to the situation where the clinical scenario started the whole process from, decide what to do, and then evaluate the whole process. So we nominate someone to do the first part, and then we do this within the group and do the appraisal aspects in the discussion, which is a mixture of learning by example and learning by doing to try and improve our critical appraisal and journal club skills. So the focus question is using a very structured approach, which is thinking about your PICO format, and you can apply it to lots of different situations, treatments, tests, prognosis, and it's just a nice structured tool so that your question can be as clear as possible. So moving on to Daphne, who's got our situation or scenario for this week.
Thank you very much, Susie. So this is a topic that comes to my mind when I'm sort of doing general pediatrics, and it's something that we come up with quite frequently. So imagine yourself as the pediatric registrar in resus, and you're managing a status epilepticus in a 16-year-old patient, and they have known epilepsy, and it looks like they're going to need intensive care admission. And this is the third time this year that you've seen somehow this patient come in with the same presenting problem of status epilepticus. And at this point, you start wondering whether or not there's any way to prevent this from happening for this patient, these repeated hospital admissions and intensive care admissions. And one thing that immediately comes to mind is whether or not having some sort of specialty care in neurology or an epilepsy specialist nurse may actually be able to help with this. Next slide, please. So that's from there. I came up with the question of, in children and young people with epilepsy, does having specialty care, specialist care, prevent hospital admissions going forward? And to be able to answer that question, I just want, thank you. Oh, and the PICO question that we came up from there, just, teasing that question down, is our population is any child and young person with epilepsy in the pediatric setting initially. The intervention is more specialist care, so having a designated pediatric neurologist or a designated epilepsy specialist nurse or any pediatrician with some sort of expertise in epilepsy. And the comparison is not having that. And our outcomes are, well, my interest was hospital admission, but as a secondary outcome, we could also think about whether or not that affects mortality. So asking that particular PICO question, I set up a search strategy and went through different databases, and I'm just showing you the PubMed one here, where I specifically chose about pediatric epilepsy using specialty as one of the factors, and finally admission as sort of the outcome in the search strategy. And it identified 8 particular papers, of which only one was relevant actually. And that was a cohort study, which is on the second part of our pyramid, which looked at the association of pediatric epilepsy care with mortality and hospital admissions. It's a data linkage study, so it's something new that we're going to be doing in this journal club. And I'll leave it to Susie and Andrew.
Perfect, thank you, Daphne. So this is just a screenshot from which will become more clear in a minute or two. This is what is the National Epilepsy 12 data in England, and it's looking at different markers for epilepsy care. And this is just a bit of an idea for that when we're looking at the paper, what data is collected within the Epilepsy 12 and what they're looking at. So this is ideally looking at the professionals. So it's a paediatrician with expertise in epilepsy and an epilepsy specialist nurse and patients who've got tertiary involvement. And this is what the data collection tool looks like. And this is the different factors that they are identifying when they do their national data. But we'll bring this back up in a little minute. But just as a marker before we look at the paper, who thinks that having more enhanced epilepsy care with your epilepsy specialist nurse, your epilepsy specialist paediatrician will improve your outcomes, such as your hospital admissions and your mortality for children with epilepsy? What do people think already? Do you think it will be better? Do you think it will be worse? You can either speak or put it into the chat.
I think it will be better.
Better, okay. Anyone else? Just Melody? George also thinks it will be better. So 1, 2, 3, 4 betters. Anyone else? Anyone thinks it might not be better? Yeah, I like how George put a little caveat. You need to have a large sample to get this effect. Okay, Yosha's kind of a bit more on the fence. Might be better, but it might not make a big difference for hospital admissions. Okay, so let's just move swiftly on. So our mission, as always, is for everyone to have a look through the paper themselves. If you can, and Andrew should be posting it into the chat. So click on the number generator. If you're 1, please look at the validity. And if you're 2, please look at the results. If you're number 1, then you should get a link to the Dropbox. Look at the paper and the CASP tool. Read the abstracts and then read the methods if you are a number 1. And if you're results, please read the abstracts and then only the results. Don't bother reading the introduction and the conclusions. And if you're super speedy, if you finish validity, then you can move on to the results. And if you finish results, then you can start having a look at the validity and work your way through.
And just to chip in, I accidentally said demographics table 1. That's a hangover from a previous week. And there's no table 1 in this one, but there is a little flow chart that shows you which hospitals could be included in the analysis. And I've gone through, we've highlighted some bits of the paper, we've put some comments in just to try and make what is not the most straightforward paper a little.
Yeah, perfect. And this is again just kind of explaining what you're going to be doing, and if you follow the CAST questions, it goes through quite nicely, making sure you're thinking, are there factors in study design that might make the effect to be biased, and the results are, what are they, how precise are they, and we'll go through that, and we'll do the applicability together. Has everyone got access to the paper and been randomised? Anyone having any problem?
And just to chip in as well, that when if you're doing validity, when you get to question 6 and it talks about follow-up of subjects, in this study, really your subjects are the hospitals. And so don't think of your subjects as patients, think of it as the hospitals that you're following up to see how their performance is.
So we will give everyone 20 minutes from now. So we'll come back just after past, if that's okay, but let us know how you're going if you need a little bit longer, and we'll let these slides just start circling.
Yeah, and while we're during that 20 minutes, if there are things that really don't make any sense or you want a bit of advice or suggestions, feel free to send us messages and we're very happy to answer, and we're here throughout.
That's us halfway through, so 10 more minutes.
Few more minutes and then we'll be back. All right, let's pull back together. I don't expect this paper will have been trivial. And sometimes I guess that's luck of the draw, really. Sometimes you ask a question and the evidence you find is easy to understand. Sometimes you ask a question and the evidence is a bit of a struggle. Susie, your screen has disappeared for me. I wonder why.
Oh, I'm just getting up the CASP. I'll be 2 seconds.
Oh, lovely, thanks. Great. So we're going to get up the appraisal skills framework form, which it's not a perfect fit for this study, but it does well enough. We'll go through it and we'll come, George, to the results. I've given you a few suggestions as to where you can find some of the results. And we'll describe it in more detail when we get there. Excellent. Here's the screen. All right. So, question 1: do you think the study addressed a clearly focused issue? So, is it easy to frame their question with a P code? Ooh, Susie's very suggestively hovering over the yes button. Yeah, if you look at the title, yeah. I mean, what's interesting is actually, what do you think that, how would you define the population for their study? Don't necessarily look at what's going on in the box. Because we're interested in children and their access to specialist care, but what is, yeah, thanks. So the population here, okay, yes, Joshua's pointing out it depends which outcome you're looking at if you're thinking about the children, but actually you can sidestep that issue by recognizing that really the unit of analysis in this study is the unit, the hospital. And so really the population in this study, as confusingly as it sounds, is really hospitals treating children with epilepsy, and in fact non-tertiary hospitals. So it's not quite what we asked for. And then the intervention, or it could be framed as an exposure because it's not an interventional study, is in a sense the proportion of patients who are accessing a type of specialist care. And they've listed it as a paediatrician who is trained in specialist in epilepsy, tertiary care for those that meet the standards of requiring it, and a clinical nurse specialist. And if you want to have the sort of C in this, I end up phrasing it as the I is more access to and the comparison is less access to, but you could just leave it out. It's just because it's a qualitative thing, or sorry, it's on a scale actually. And then the outcomes in the study, what outcomes do we have? Joshua's already said mortality. And admissions, and both at hospital levels. So it's sort of hospital level mortality and admission for the patients. Yeah, unplanned admissions they've done, haven't they? Okay, so what do you think about the recruitment of the cohort? The cohort being the hospitals. Yeah. Yeah, so trying to capture the population across England. Yeah, anyone got any expertise on the epilepsy 12 audit? Does anyone know how good its coverage is? Joshua, you like your neurology. Don't want to put you on the spot. Okay, so you're saying that the tertiary exclusion may get rid of some hospitals that are not really fully tertiary. I went away and I downloaded some of the historic epilepsy 12 reports. Their coverage is good, actually, and they get a really good responses. They cover the vast majority of the units. So in that sense, their recruitment is good. But what did we see in figure 1? Does anyone have a look at figure 1, which shows this sort of flow diagram? Yeah. Yeah, so Defner's pointing out there's quite a lot, particularly if you look at so it depends on the exposure they're looking at, how many they lost. When they were looking at the epilepsy, access to a paediatrician with epilepsy expertise or epilepsy specialist nurse, they were getting 99 out of 110 or 74 out of 101. Sorry, it's 101. So 99 out of 101, which is great for the mortality analyses. But when they get to the paediatric neurologist, they're having to drop out quite a bunch because they have so few patients who required tertiary neurology care. So something we have to bear in mind. But given the methods that they were using, and we've talked about the fact you need large numbers for these sort of studies, it seems like that's unavoidable. So we say it's acceptable, but we would have liked it to be better. Okay, and what do you think about the measure of exposure? So exposure in this study, well, what do you think exposure is in this study? Yeah, so specialist care, and there's sort of 3 dimensions of that, absolutely. And I guess it's a tough question to ask because you need to know a little bit about the epilepsy 12 audit, but I went and looked at it and it looks like each centre probably reports, I think it was maybe 20 to 25 patients on average for the study. It's a period of a year, and they've done some sort of revalidation to see what happens when someone re-enters the data, and it seems that most of the time they get the same answers. So it seems like the exposures are well measured, that this epilepsy 12 audit is good at measuring what it purports to measure. All right, and what about outcomes? So that's outcomes of admissions and deaths. Okay, so Defner's coming to confounders, but we'll get to that. What do you think of? Do you think the way by which they've measured the outcomes? So this is where it comes to the data linkage that we mentioned, which is a slightly novel aspect of this study. We've not used one like this. So they were measuring deaths by getting them from death records, Ordnance Survey mortality data, and they were defining the cohort of children that they were interested in based on hospital episode statistics, which said that they'd had an admission with epilepsy within a defined time period. Okay, so Defner's saying hospital episode statistics data should be accurate, you'd hope. Yeah. But it's fair. So this is not sort of, this is not someone sitting down and going through each hospital's records and manually extracting lots of data. This is done at aggregate level. What's clear is that there were some hospitals they couldn't use because the hospitals had merged or split or whatever, and it became unanalysable. So they lost a few for that reason, I think. Yeah, and Defna, who is, I know, interested in data linkage, says that they don't really give us much data about how successful their data linkage was. All right, next one. What do you think about, so just a two-parter here, and you can sort of go with whichever. So do you think they've identified the important confounding factors and have they adjusted for them? Yeah, I think definitely you were starting on that a moment ago. Yeah. So actually, I mean, the list, I counted them up. I think you'll see a little comment from me. I counted up how many different confounding factors they referred to, and I counted 18 plus 4 if you looked at the adjustment for post-transition things. Yeah, I mean, they threw in a lot of things, but I guess I was left wondering, some of them I was a bit, I was just wondering to what extent they were just using the stuff that just happened to be in the epilepsy 12 data versus, stuff that they would automatically have thought was important. So I've not got in my head whether important confounders have been missed. Did anyone have any thoughts as to what might be important confounders? I always think confounding is much more difficult to think about when you're looking at such a high level, at hospital level. We think about confounding much more at the level of individual patients. I think it becomes harder when you're looking at aggregate data. Fine. And what do you think of, okay, geography? What do you mean by geography, Defna? Do you want to unmute or?
Yeah, as in distance, some hospitals will be quite distanced from various locations, which may obstruct the way you're managing care. That's
you're thinking sort of rurality, to use an awful word. Yeah. And do you think that rural versus non-rural could have an impact on, access to specialist care?
Absolutely. I think, just by looking at London, there's lots of tertiary hospitals that can provide you that care, depending on where you are, and you can get to it quite quickly. Whereas I think other parts of the UK, not so easy.
Yeah. Okay, no, I think you've come up with a really interesting potential mechanism of confounding. If rural hospitals find it harder to refer people to tertiary care, and if rural hospitals, people live further from the hospitals, and that's having some effect on mortality, then yeah, absolutely. Okay. And what do you think, what do people think of how they've taken account of the confounding factors? It's a bit statsy, essentially it's regression, and they've thrown them all in.
Have we lost Andrew, Susie?
Yeah, it says he's speaking, but can anyone else hear him? No.
I don't think I can. Andrew, we can't hear you.
Defna, do you want to take over, or do you want me to take over?
Yeah, I'm happy to take over if you're writing down.
Yeah.
We were just talking about how the analysis for the confounding factors were done, right? We'll just wait and see if Andrew comes back. So essentially, the in what Andrew was talking about was about the regression analysis that includes essentially you in the regression analysis you put these various variables in and see if any of them affect the outcome. So that's essentially how they did it. A little bit of a black box way, but it's definitely a well-recognized way of doing it. So that was my opinion on it. Did anyone else think of anything at this point, or? Okay, we'll go up to the follow-up, because then we can get onto the results. So just very quickly, the follow-up that they talked about was throughout the audit, the 2009-2015 period. So it's a long enough period to be able to have a look and see. I'm just aware of the time, and I wanted to get to the results bit because George had some questions about that part. So, oh, Andrew's back. Are you back? Possibly not. Okay. So in terms of the results of the study, George, can you bring back your question? What did you think? You said you understood the admissions bit, but the mortality bit was a little bit vague. Can you tell us what you thought of the bottom line for the admissions part this paper was mentioning?
Hi, sorry.
Yeah.
So the question that I was saying was that I could kind of find and follow where they were saying in terms of the reduced, rather with the reduced admissions, or actually increased admissions when there was reduced access to an epilepsy nurse. And
Yes.
they were showing that was a kind of significant difference.
Yeah.
And you could see that with their box plot.
Yes.
There's issues with that in terms of it doesn't actually kind of follow the trend with other access things, but that's parked by the side.
Yeah.
Then
You're
there's
right.
also the question in terms of the mortality in the neurologist. I'm still trying to work out a little bit exactly which part that is, because I know there's figure
Table 2 and 3, I think. Yeah.
So that's the admissions, and then
Yes.
table 3 again. In terms of saying that the total deaths, so they're saying that you're getting 4% with the neurologist, and then kind of less with the others, but even still, that's not a significant difference as I'm seeing it.
So I think it's a bit confusing, but I think the units are categorized into good, moderate, and poor. So
Yeah.
I think the good bit is the bit where the pediatric neurologist is available at all times, whereas the poor is the ones that they don't get as much sort of pediatric neurologist input, was what I understood from it. And so I think if you look all the way down to the p-value, good versus moderate and poor, it's the p-value, like it's statistically significant going from 2% to 5% in that scenario. So I think that's what they're referring to in terms of having a pediatric neurologist in post-trans, like this is specifically about post-transition though. So after they've transitioned into adult services, if they had a pediatric neurologist in the beginning in a sustained manner, they significantly had less deaths after transition.
Yeah, and if you want to look at the data more directly, the supplementary material is in the folder. Sorry for my absence, internet broke. If you open the supplementary material, figure 1, that gives you the sort of scatter plot. And it might either increase or reduce your skepticism. You can certainly get from the scatter plot that the numbers are small because a lot of them are 100% or 50%, or 0%. And I suspect that's because of the large number that had only 2 patients. Because they excluded those that had, I think, did they say they excluded those? Yes, with fewer than 2.
Yeah.
So I suspect that quite a large number of the hospitals had only 2 patients who were eligible, and they either referred all of them, none of them, or one of them. And then you've got other hospitals that must have had more numbers that are coming out with sort of percentages of.
So the numbers are very small. But actually, just for the sake of looking at those tables, Andrew, just so that from what George was saying, I think table 3 is interpreted in that way. And then when you look at table 2, this is just giving you the correlation coefficient, basically. So if you look at the top bit of table 2, you'll see that so it's negatively associated. So the more neurologists you have, the less deaths you're having. And if you look at adjusted for population unit severity characteristics, post-transition deaths, that correlation coefficient just happens to be statistically significant as well. Does that make sense, George?
Yeah, thank you.
Perfect. Sorry, Andrew.
Yeah, no. I'm just popping in some text here. I'm just trying to edit it before I send it. Quite difficult to spot carriage returns in here because it tends to just submit the text. Anyway, but basically, so in terms of mortality, they had a negative correlation very crudely for involvement of tertiary specialists. Didn't find any association with specialist nurse involvement or with paediatricians with expertise. And then when they did their more fancy regression analysis, which was trying to take into account all the confounding, they said 6.4% absolute reduction in mortality, which is the estimated difference between those with 0% referrals and those with 100% referrals. But the overall mortality in the cohort was 5.7%, which seems to me quite high. They're saying 5.7% of children who they considered the mortality for, which was 10 to 18-year-olds who were admitted to the hospital at least once with a diagnosis of epilepsy. They're saying 6% mortality by the time of their sort of late adolescence. What do you think of that?
Sounds pretty small.
Well, the mortality pretty small.
The absolute reduction of 6%.
Oh, I see. No, but that's an absolute reduction, so that's similar to the overall mortality.
Oh,
yes,
sorry, sorry,
George,
I got stuck in the first bit. Sorry, I was just reading through the.
Yeah, George, that was my thought as well. That's quite a high mortality rate, and I have to say my assumption is that this epilepsy diagnosis, a lot of the adolescents who are being admitted to these hospitals with epilepsy likely have quite complex underlying neurodisabilities. And actually, I wonder if what they're really measuring is the mortality rate of those children. And I think that that's likely to be a lot more than to do with their community pediatrics, yes, neurodisability, and I'm not sure how that would be treated by the epilepsy 12 audit. I'm not sure how, I presume they would consider that as a tertiary referral, but I don't know if that's the thing that was being measured, because the particular cohort they were interested in for the tertiary referrals, that was the under. But I agree that we're looking at epilepsy mortality here. Precision we won't focus on, but they give confidence intervals for everything. They're pretty wide, and a lot of the p-values are, shall we say, borderline. You can always tell there's a borderline p-value when a paper reports both the two-sided and the one-sided p-value, because the one-sided p-value is always half the size of the two-sided p-value. So it's one way of making your p-value smaller. So that brings us to the sort of perhaps the critical issue here, before applicability is even an issue. Except we haven't mentioned the admissions. Definitely, we must mention admissions. I've skipped past that. What did you think of the data for admissions? George, you were talking about that and you were looking at figure 2. Did I miss us talking about that?
No, you didn't. We just talked about mortality, actually. We talked about the box plot very briefly, but I'll leave it to George.
Yeah. Okay, but yeah, if we go to figure 2, George, what did you make of figure 2?
So my understanding, reading it, was that yes, you seem to have a significant increase in hospital admissions when there's reduced access to an epilepsy specialist nurse. But actually, when you then look at the other box plots, lots of them seem to have increased ratio of observed to expected epilepsy admissions. And when you have a look, you would expect, if it was the effect of the specialist nurse, that there'd be a kind of trend towards those getting better access to nurse, at least being kind of above the line, even if it wasn't necessarily enough to show significance. There just doesn't seem to be a consistent trend in lots of that to kind of definitely different.
It isn't, or at least there's a sense that it's showing that for the ones that got worse, the admission rates seem to have gone up, but for the ones that have got better, the admission rate doesn't seem to have gone down. So that's one thing. We would like to see the effect in both directions, I guess. There certainly seems to be, we're seeing a very consistent effect regardless of access to paediatricians with epilepsy expertise. And again, with the neurologist, I come back to the fact that the numbers of sites that could be included here was very small. And so the confidence intervals become wide, and I just think that becomes much less interpretable. Okay, which results are you more convinced by? The mortality result, that access to tertiary paediatric neurologists is reducing mortality of the adolescents and the older children, or that worse access to epilepsy specialists, diminishing access to epilepsy specialist nurses increases the unplanned admission rates. You can type answers or speak, whichever. Well, I'll give you my view while you may be thinking. Susie. Yeah. So the mortality one, I just find it hard to buy because I'm not sure what they're really measuring. I'd love to know more about actually, who these children were who died, and whether the death was related to epilepsy. I think that would make things more plausible. I think also, to me, this study should be very well powered to detect an effect of paediatric neurology input on reducing admissions. And actually, so if we can't even see a signal that reduced paediatric neurologist input is causing more unplanned admissions, then why is it that we can see a signal in death, which should be much harder to detect? So there's something funny there for me that I can't get my head around. Whereas the hospital admissions, I guess, it seems to me as much more plausible that loss of an epilepsy specialist nurse would mean that unplanned admissions become more likely. That seems very plausible to me, and so perhaps I'm more inclined to accept that finding. It seems less surprising, less striking than this really big magnitude change in mortality. George is sort of, I guess, similarly a little bit sceptical. I guess on that basis, unless anyone is totally convinced by the results, there's probably not a vast amount of local application to think about. But what we end up coming back to is, well, are the goals of the aims of the Epilepsy 12 audit, are they all good things? Is it right that children should be having access to tertiary neurology, when they're complex or very young? And some of it you might just say it's motherhood and apple pie. They're things that actually people would not argue with, that we should be doing. But I think we might differ in how strongly we believe that this evidence really sort of proves that one thing is linked to the other. And I suspect if you really wanted to get down to it, you'd probably want to be looking at individual patient data.
I think if I were setting up a neurology service and I was asked to put money in to put, would I invest money in a specialist nurse if I work in a DGH, for example? Just by looking at this data, I don't think I'm that convinced.
Yeah, I suspect there may be much more useful data that comes out of the audit because they do survey patients and parents. You can read it all, and there may actually be much more significant, meaningful stuff that comes out about qualitatively and quantitatively what people, report is the impact of paediatric specialist nurses on their quality of care, and that may be very important as well. So there's more than just numbers and deaths and things like that. There are other ways we can look at these things. I mean, Joshua, if I can put you on the spot, I'm interested to know whether you have any other thoughts or any deviations from what we've been saying. Oh, been trying to find a document with the simplified results. It was in the Dropbox. I've just put some highlighting on it, that's all. It may depend what you're trying to open it with. And then in the Dropbox as well, oh, Epilepsy 21. I think I can paste a link to you for that. Epilepsy 12, it's called actually. All of the Epilepsy 12 stuff is there on the Royal College website, and they've got historic reports here, and that's what I went to look at because that's what this data is based on. Fine. Well, look, it's 1 minute past 2, so I think we should wrap up. I think it's been a challenging paper. I hope it hasn't caused you too much stress, and even if it hasn't convinced us of anything strongly, hopefully we've learned something from reading it. We should probably go to the slides just to wrap up. I'm just posting the usual stuff. I'm just posting some links to resources you may find useful, including some online e-learning courses that I think are both free. Archimedes in the Archives of Disease and Childhood, I really recommend. It's really short summaries of the evidence, answering particular questions, and all done by trainees like us usually, and usually very interesting and relevant stuff that people collect. Feedback, I don't like to bully you into giving feedback endlessly because you've been doing it forever. If you did want to give us some feedback, you're welcome to fill it in there. You're also welcome to email me here. The newer results, yes, I don't know about the newer results. I only looked at the older stuff, Joshua. I think we've all noticed that attendance at these sessions, and I think the weekly London school sessions overall have been declining as people get back to more normal work patterns and more normal departmental teaching. So I think our feeling is that we may make next week's one the last. We'll discuss it with the wider team, but we may try and go out with a bang next week. That would make 12 weeks of journal clubs, 3 months, and we'd all be very happy with that, rather than sort of limping on endlessly. But we are enjoying it. We've enjoyed having you here. Thank you for your contributions, and all being well, see you next week. Thanks, guys.
Thank you very much. Bye-bye.